So the final stretch of our course here, this is going to be liver portal hypertension and liver transplantation. I'm Robert Wong, a gastroenterology hepatology staff physician at the VA. And we have a really exciting lineup of speakers and topics today. We have a slight change in the programming, so Dr. Kumari is actually going to go first, and then we'll follow with the rest of the speakers. So first speaker, Dr. Radhika Kumari is a clinical associate professor in transplant hepatology at Stanford, and she's going to tell us what's new and exciting with hepatorenal syndrome. Welcome.
Good afternoon, everybody. So I think the coffee break should have perked everybody up. Thanks for staying for the last session today, and thanks to the panel for giving me the opportunity to talk about hepatorenal syndrome. No conflicts. So today we'll talk about definition and pathophysiology, diagnosis, and management of hepatorenal syndrome. So we all know that hepatorenal syndrome is a late complication of cirrhosis, but the reason it's so important, even though it makes a late entry, is because of the mortality rate associated with it. There is 50% mortality within 2 weeks if untreated, and that's why it is very important to diagnose it early and treat it early. Starting 2019, the definition of hepatorenal syndrome has been changed, and the change has been done basically to diagnose it early and treat it early also. Hepatorenal syndrome type 1 is where the creatinine increases by 0.3 milligrams per deciliter within 48 hours, or the creatinine increases by more than 50% in the last 7 days. So that is type 1. Type 2 is chronic, where the creatinine increases and slowly creeps up within weeks. And the mortality rate is still 50% within 6 months, but the mortality rate is higher for hepatorenal syndrome type 1. So the pathophysiology, for every reaction, there has to be an action. So there has to be a trigger here. So the triggers are basically infection, translocation of bacteria. So any infection releases vasodilators into the splanchnic circulation and leads to splanchnic vasodilation, in terms leading to decrease in the renal blood flow. The other triggers like GI bleeding, large volume paracentesis, cirrhotic cardiomyopathy, and beta blockers, they all decrease the effective arterial volume, leading to decrease in the renal blood flow, leading to increase in the sympathetic renin-angiotensin and vasopressin systems in our body, leading to further renal vasoconstriction, leading to hepatorenal syndrome type 1 and type 2. So what are the diagnostic criteria? This is the easiest slide. So this is a diagnosis of exclusion, basically. There are no serum biomarkers for diagnosing hepatorenal syndrome. We need to make sure there is no proteinuria, no hematuria, and no obstruction causing hydronephrosis by renal ultrasound. And the presentation is basically the primary etiology, basically presenting with hypotension if the patient has GI bleeding, and if they are hypovolemic, excessive use of diuretics, or significant volume overload at the late presentation of hepatorenal syndrome, and symptoms pertaining to etiology, basically. So what is the management for hepatorenal syndrome type 1 and type 2? So most of the talk will be about type 1. So the definitive treatment we all know is liver transplantation or simultaneous liver-kidney transplantation. Most of the talk will be about the bridge treatments. The bridge treatments are basically the bridge. They are not the definitive treatments. So bridge treatments are, again, preventable and curable treatments. So the preventable are removal of nephrotoxic agents. So if our patients are in the hospital, be cautious about the medications that we give to these patients. Any antibiotics, any supplements that these patients take as outpatient, we have to educate these patients. Stopping diuretics in a timely manner to increase the renal blood flow is important. Stopping beta blockers. So beta blockers, educating about beta blockers is very important both to the patient and to our referring physicians. So there is a window period beyond which we should not be using beta blockers when patients have refractory encephalopathy, refractory ascites, hyponatremia, and hypotension, and the early onset of when we start seeing the creatinine creeping up. We have to educate our patients and also the referring doctors as to why we need to stop it and why patients should be getting banding for esophageal varices prophylactically and treating the primary cause for sure. So this is the crux of our talk. So basically, the bridge treatments, which are curative. So remember, the two basic pathophysiology factors are decrease in the renal flow because of hypovolemia. So we use volume expanders like colloids or albumin, and vasoconstrictors, which lead to splanchnic vasoconstriction, and in turn leads to increase in the renal blood flow. If this combination doesn't work, then we are going to renal replacement treatment, hemodialysis. But again, remember, it's just a bridge treatment. The definitive treatment and the last treatment is liver transplantation or simultaneous liver-kidney transplantation. So we all are used to our cocktail treatment. As soon as our patient rolls in, we start giving them octreotide, albumin, and midodrine. The reason this treatment is used so widely is because it's widely available. It's because of ease of administration, and it is less expensive. But the answer to the cocktail regimen is it does not work. So meta-analysis has been done, and it has shown that it does not improve survival. It does not help in long-term reversal of HRS. In spite of this, we still use it because, again, it is less expensive. It's widely available in every pharmacy. So, and also, midodrine can be given orally, so it's easier to discharge a patient on renal replacement treatment on midodrine dosing. So octreotide basically works by blocking the release of glucagon, which in turn leads to decreases the splanchnic vasodilation, basically. And midodrine works on alpha-1 adrenergic receptor, increasing the renal blood flow. And albumin has two properties. It is a volume expander, and it is an anti-inflammatory treatment. But again, it is expensive, but it does not, it is less expensive compared to other treatments, but it is still expensive. So we have to be mindful of the treatment and how much albumin we are using for our patients. So then the next treatment is the biggest news, I guess the biggest update in HRS is the approval of terlipressin. So terlipressin has been recently approved, but terlipressin was the mainstay of treatment worldwide, especially in EASL guidelines. That's the first line of treatment using terlipressin plus albumin. We do not have it in Stanford Pharmacy. I have 2 patients right now that I want to use it on, and we do not have it. And the person approving it is on vacation, so until she comes, we cannot use it. So there are still a lot of logistical issues in using the terlipressin. So what is the difference between norepinephrine and terlipressin? So norepinephrine in Stanford, we can use it in non-ICU setting, but not in other hospitals. We still have to use it in ICU setting. And trust me, whenever we hook our patients on norepinephrine, we start getting phone calls. I have to transfer a patient out. They don't want to take the patient because the patient is on norepi. You have to explain that this is for HRS. I have to get a patient down for a bleeding treatment to endo. They don't want to take the patient because the patient is on norepi. So there are a lot of logistical issues there also. But there have been studies done which have shown that terlipressin is superior to norepinephrine. And norepinephrine is started at 0.5 mg. The max dose is 12 mg an hour. Terlipressin is given, either you can give it in boluses every 6 hours, or you can give it as continuous infusion. Continuous infusion is preferred because there are less side effects. So both norepinephrine and terlipressin can cause ischemic side effects. So we have to be really careful, and they have to be watched every 4 hours, nursing staff. And pulmonary edema, because we give such high doses of albumin with this combination, it can cause pulmonary edema. Terlipressin has more side effects than norepinephrine, so it's very important to be mindful about that too. So there is a black box warning in the prescriber's information that if the patient has grade 3 liver failure, or if the pulse ox is less than 90%, then terlipressin, terlipressin should not be given to our patients. So now we know terlipressin is superior, but when should it be actually started, early versus late? So if a patient, there was a post-hoc analysis done for 3 randomized studies, reverse, confirm, and OT study, where it has been shown that terlipressin's efficacy is more than 80% if used in early stage when the creatinine is between 3 to 5 milligrams per deciliter. It does not work if the creatinine is more than 5 milligrams per deciliter. It is true in terms of patients being alive without needing renal replacement treatment, and also it is true also in terms of overall survival for these patients. So the earlier we recognize, the earlier we treat, the early we save the patient, the survival improves. It works as a good bridge treatment, avoiding renal replacement treatment, improving survival for our patients. But this is the silent elephant in the room. Why is the hospital not acquiring, or why is it so hard to push it through? Is a pack of norepinephrine is $35. Terlipressin is $1,000. There was another slide with Stanford acquisition costs. I could not put it there, so I had to cut it out. And then hemodialysis. So after our treatment, the last and the late resort is hemodialysis. We all know how hard it is to get lines on our patients. They have bleeding complications, they have infection complications, and they are hypotensive. It's very hard to discharge a patient when they are on dialysis because of hypotensive complications. And there has been no improvement in survival because, again, this is a bridge. It's not a definitive treatment. So just 1 to 2 slides on transplant. So which is the patient so the definitive treatment is transplant, which is the patient that we determine liver versus simultaneous liver, kidney versus safety net. So if our patients have CKD for less than 90 days, if they have been on dialysis less than 6 weeks, and they do not have intrinsic kidney disease, they only qualify for a liver transplant. But if they have more than 90 days of CKD, more than 6 weeks of dialysis, and they have intrinsic CKD, they do qualify for simultaneous liver kidney transplant. Once they get transplanted, if there is no renal recovery for 60 days, then we can send the patient back to our nephrology colleagues to be evaluated for safety net. And they can we can still give them more time if the patients want to wait. Some patients, they want to wait within a year, and we can still wait, but we can get them listed so that they can be in the safety net, though. So again, just remember 2 basic concepts: increasing volume and using vasoconstrictors. But while doing that, remember to evaluate a patient for transplant. Don't forget that part, because that's the definitive treatment. Thank you.
Next, we have Dr. Deepti Dronamraju, who's a transplant hepatologist and clinical associate professor of medicine, and she'll be giving us updates in the management of portal hypertension.
Hi, everyone. My name is Deepti Dronamraju. I'm one of the hepatologists. My practice is predominantly in the East Bay at Stanford Tri-Valley. And today I've been tasked for the next 15 minutes to chat with you about updates in the management of portal hypertension. And there's been a lot of interesting studies that have come out recently regarding portal hypertension in the past few years, but I only have 15 minutes. So I'm going to really focus on the role of non-invasive fibrosis in assessing clinically significant portal hypertension, talk to you guys about why carvedilol might be the beta blocker of choice in compensated cirrhotics, and then help define who might be the candidate to go for a TIPS preemptively after a variceal bleed. So cirrhosis is a multi-stage disease process with a period of fairly prolonged period of compensation followed by an acute period of decompensation. And these are really 2 different disease entities, as you can see by the mortality rates. While patients are in a compensated state, their life expectancy is quoted to be around 12 years or more. And when they develop a decompensation, which is defined as the development of ascites, hepatic encephalopathy, or variceal bleeding, that mortality goes down considerably, down to about 2 years. And the major driving force of what drives people from compensated into a decompensated state seems to be the worsening of portal hypertension. So the paradigm here is really changing to now not just manage the decompensation, but to try to manage the portal hypertension to prevent the decompensation in the first place. And said in another way, this is another study that shows very nicely in this diagram how in the earliest stages of compensation, your risk of dying annually of your liver disease is negligible at about 1%. Okay, there. And as you progress through the stages of cirrhosis, from varices to ascites to varices that bleed and ascites that gets infected, your risk of dying annually of your liver disease is much higher at a 57%. And so if all of this is being driven by portal hypertension, let's chat a little bit more about what portal hypertension actually is. So portal hypertension is defined as the increased pressure in the portal system due to the resistance from the underlying cirrhosis. And this is due to the fibrotic bands that lead to increased resistance and less pliability of the liver. And the body's then compensatory mechanism to cause splanchnic vasodilation that then leads to increased portal vein flow. The point of resistance really helps us define what the source of the etiology of the portal hypertension is, as shown in this diagram, whether it's posthepatic, intrahepatic, or prehepatic. Again, a normal hepatic venous pressure gradient is between 3 and 5 millimeters of mercury, and clinically significant portal hypertension is defined as 10 millimeters of mercury or greater. And so clinically significant portal hypertension of 10 millimeters mercury or greater is the gold standard for making that diagnosis is doing this HVPG measurement, which is an invasive procedure that involves fluoroscopy, ultrasound guidance, where you have to thread a catheter into the IVC. And obviously, it's not something that we can use in our daily clinical practice. And so at the latest Bavino meeting, which is a meeting of experts kind of coming together about what should be the best practices in portal hypertension, have actually included in their most recent algorithm using non-invasive measures of portal hypertension. And in this measurement, they're including transient elastography to measure liver stiffness. So this is the algorithm that was provided at their after their meeting this past 2021 meeting. And here you can see that liver stiffness, if you have a stiffness score of less than 10 to 15, with platelet counts greater than 150,000, and you do not have any evidence of portal hypertension on imaging, then the likelihood of having clinically significant portal hypertension is low, and you don't have to worry as much about these patients having varices. And they actually said that if your stiffness score is less than 20 and your platelet count is greater than 150, you may be able to avoid endoscopy in these patients for the purposes of screening for varices. I'd also like to point out that there's been a little bit of change in nomenclature at the Bavino meeting. They're changing the word compensated cirrhosis to compensated advanced chronic liver disease. And this is really to highlight that it's not so much the histologic diagnosis of cirrhosis, but rather the portal hypertension that seems to be driving the disease process. So the mainstay of therapy for years and years has been non-selective beta blockers, and this is just the ASLD algorithm that I listed here with propanolol, nadolol, and more recently carvedilol, along with band ligation. Beta blockers work by lowering the portal pressure by decreasing the portal venous inflow. Carvedilol is atypical non-selective beta blocker in that it has mild alpha-1 adrenergic activity as well that leads to decreased resistance at the level of the hepatic vasculature and may lower the hepatic vascular tone. And so as a result, it may also drop the mean arterial pressure more so than the other beta blockers, but it may be better. I'd also like to point out that for carvedilol, while you do have to worry about the blood pressure, you don't necessarily need to titrate it to the heart rate of 55 to 60 like you would for the nadolol and the propanolol. So what is the role of non-selective beta blockers in the management of clinically significant portal hypertension in patients who have not yet had evidence of variceal formation that we know of. So this is a trial that came out of Spain in 2019. It was published in the Lancet journal, the Prodesky trial. This was a multi-center trial, like I said, randomized control trial out of Spain that looked at the efficacy of beta blockers in preventing decompensation and mortality in patients with clinically significant portal hypertension and compensated liver disease. So this was an interesting study because these patients actually underwent that invasive HVPG measurement, and they actually evaluated what their response to IV propanolol was during the measurement. And if they showed improvement, drop in their HVPG in response to propanolol, then they were randomized to either a propanolol or placebo group. And if they didn't have a more than a 10% drop in their HVPG, then they were actually randomized to either a carvedilol or placebo group. So in that way, they were able to randomize about 200 patients either to a treatment with a beta blocker or placebo. And what they found was that decompensation occurred in 16% of the patients that were treated, but in 27% of the placebo group with a hazard ratio of 0.51. And the main difference here, the main decompensation that got prevented was not variceal bleeding, but actually the development of ascites. And so in this group that was treated with non-selective beta blockers, ascites occurred much less frequently at 9% as compared to 20%. And so how does carvedilol fare compared to propanolol in the case of secondary prophylaxis, patients who've already bled and have undergone banding, and now you're deciding to put them on a beta blocker? So this was a retrospective analysis of patients who were banded and then subsequently underwent HVPG measurement again, and were randomized to either propanolol or carvedilol. And here also, carvedilol outperformed propanolol in terms of response of their HVPG dropping. They had a much more significant drop in the HVPG, and that then correlated to decreased risk of variceal rebleeding, as well as other non-bleeding decompensations. But again, this was a small retrospective study of 87 patients. And then more recently, there's not been any data to suggest that the beta blockers show any survival benefit. And this is a journal article that came out in 2022 in Hepatology that looked at carvedilol in compensated cirrhotics as a potential beta blocker of choice that showed a survival benefit. So these are patients who had compensated cirrhosis and evidence of clinically significant portal hypertension, this was a meta-analysis that included 4 randomized control trials. And if you look at the forest plots here, there was a significant benefit in survival improvement with carvedilol as opposed to not doing anything or just doing band ligation. So does that mean we should put everybody on carvedilol? I think the jury is still out on that. The ASLD guidelines, which came out, I think the latest ones are from 2017 or 2018, say that in the earliest stages of liver disease that our best bet is to eliminate the etiologic agent that is causing the liver disease in the first place, like treating their hep C, addressing the alcohol use issues, and that at that very earliest stages that there's not going to be that hyperdynamic circulatory state that would benefit from beta blocker, and that traditional beta blockers like propanolol, nadolol, carvedilol, or esophageal variceal ligation is recommended for the prevention of the variceal hemorrhage. The Baveno 7 criteria actually says that carvedilol is the preferred non-selective beta blocker in compensated cirrhosis since it's more effective at reducing the HVPG, and it should be used as first-line therapy because of its alpha adrenergic activity. I think in decompensated cirrhotics, you'd have to worry a little bit more about dropping their pressure because of that secondary effect as well. Let's move on to the management of acute variceal bleeding. So this is the algorithm from AASLD. So if you have a suspected variceal bleed, you do your standard volume resuscitation with conservative PRBC transfusion, aiming for a hemoglobin of 7 to 9. You may give the patient, you'll be giving them IV antibiotics, and you'll start vasoactive drugs. And then you'll perform an emergent endoscopy within 12 hours and perform band ligation. And then you have really 3 categories of what's going to happen to that patient thereafter. You either start the vasoactive drugs and continue them for 2 to 5 days and plan to discharge them on a non-selective beta blocker once they've stabilized. And if in that setting they rebleed, then they'll go for TIPS. If you have no success banding them and they're having ongoing bleeding and you're putting a Blakemore in, then you're going to send them for a TIPS. And then this is the category that we'll focus on. You have a patient who you've successfully banded. They're no longer bleeding, but they're pretty sick and they're high risk of rebleeding. And this is the Child-Pugh Class C patients, as well as Child-Pugh Class B patients with active bleeding on EGD. And the ASLD algorithm here recommends that we actually proceed to an early TIPS. And so let's look at the data behind that. So this is a meta-analysis that came out in gastroenterology in 2021 that looked at 3 randomized control trials and 4 observational studies that totaled a total of 1,300 patients, with the primary endpoint being survival, 1-year survival, in patients who received a preemptive TIPS versus patients who received drugs plus endoscopy. And it actually was able to look at patients by Child-Pugh class, how they varied in terms of their survival. And so what you can see in the top curve, this is Child C patients. There was clearly a benefit with preemptive TIPS as compared to drugs and endoscopy. And then the bottom 2 curves are actually the Child-Pugh B patients. And you'll see here that the benefit was really in the Child-Pugh B patients with a score greater than 7. For those patients who are Child-Pugh B with a score of 7, there really wasn't as significant of a difference. So the benefit really here seems to be for patients who are Child C score less than 13 and Child-Pugh B with active bleeding at the time of endoscopy and a score greater than 7. All the studies that were looked at in this meta-analysis had excluded certain patients, as they all do. And so patients who are younger than 18, older than the age of 75, who had a Child-Pugh score greater than 13, had HCC outside of Milan, who had bled from isolated gastric or ectopic varices, had a prior TIPS or a portal vein thrombosis with total occlusion, renal failure, heart failure, and pregnancy were excluded. So this you should take into consideration when you're looking at this data. And lastly, I'll just point out that there was a meeting of the ALTA Consortium, which is Advancing Liver Therapeutic Approaches. It was a multidisciplinary group of North American experts that were met to look at practice-based recommendations for the use of TIPS in patients with any cause of portal hypertension. And they also kind of recommend the same as the ASLD guidelines, that a preemptive TIP should be considered in patients who've been successfully banded, but who meet high-risk criteria of being Child-Pugh Class C, or Child-Pugh Class B with a score greater than 7 and evidence of active bleeding at the time of endoscopy, and that this decision to go towards a preemptive TIPS should be made within 72 hours post-bleed, unless they have some other contraindication to a TIPS, rather than waiting for the patient to potentially re-bleed and then talking about a rescue TIPS or a salvage TIPS. So my take-home points that you should really just kind of take with you is that the goal is, in liver disease, the paradigm is really shifting towards managing portal hypertension and trying to manage portal hypertension in a way to prevent decompensation in the first place and try to keep patients in a compensated state for as long as possible. There's an increasing role for non-invasive fibrosis assessment in making the assessment of clinically significant portal hypertension so that it's more accessible for us in our clinics. Carvedilol may be the preferable non-selective beta blocker, especially in the compensated patient. And then finally, the timing of TIPS matters, and that you might want to consider preemptively TIPSing a patient who's going to be higher risk for rebleeding, rather than waiting for them to potentially rebleed and then do a salvage TIPS. Thank you so much.
The next talk is me. So I'll be talking about cirrhosis. Can we change the trajectory? And as we're getting a slide set up, just a reminder to everyone, please submit your questions either online or through the little QR code, and then we'll have a panel discussion at the end with all the speakers. Great. So I'm Robert Wong. My clinical practice is over at the VA hospital in Palo Alto. And today, in the next 15 minutes, the topic of my talk will be on cirrhosis, with the question of, can we change the trajectory? So objectives will be to understand brief current updates in the epidemiology of cirrhosis in the US. I'm going to spend a little time describing the benefits of antiviral therapies in reducing disease progression in patients with cirrhosis due to viral hepatitis. And then at the end, talk about the benefits of antiviral therapy in potentially contributing to regression of cirrhosis or fibrosis, again, focusing on viral hepatitis specifically. Some background, some of this you may have heard or already know. Cirrhosis and chronic liver disease is the 12th leading cause of death in the US. And recent data suggests that approximately 52,000 deaths occur related to chronic liver disease and cirrhosis in the US. The benefit is we've seen some improvements in that with the advent of direct-acting antivirals, both for hepatitis C as well as therapies for hepatitis B lead to reducing risk of viral hepatitis-related cirrhosis and HCC. We've also seen some other changes in the epidemiology of chronic liver disease with emergence of NAFLD and NASH, and also with alcohol-associated liver disease, especially in the pandemic, and now we're still seeing some persistence of that in the so-called post-pandemic era. Here's some preliminary data to really emphasize the burden of chronic liver disease in the US. These are data using something called the nationwide or national inpatient sample, looking at the trends in hospitalizations related to chronic liver disease. And as you can see here in this study published a couple years ago, that the trends in hospitalizations related to chronic liver disease has continued to rise. Continued to rise about 23% from 2012 to 2016. Also important to understand is the healthcare resource utilization and burden associated with this. And over the same period, we've seen a parallel rise in costs. And this is primarily, these data are only hospitalization costs. But even then, in 2016, the costs associated with chronic liver disease and cirrhosis is nearly 19 billion. And when you think about other costs, indirect costs or outpatient costs, pharmacy costs, you can imagine that the numbers are much, much higher. What about mortality? These are data published a couple years ago by Elliot Tapper's group in the BMJ, and they used a CDC database called the CDC Wander. They looked at data from 1999 to 2016, and as you can see here on the graph, they showed that during this period that cirrhosis-related mortality increased by 65%. Specifically, from 2008 to 2016, there was an annual increase of 3.4% and 3% for cirrhosis and HCC-related mortality, respectively. When they looked further and tried to understand what were the drivers of this increased mortality, some very concerning findings were identified, and they saw that actually young individuals, those aged 25 to 34, had the highest average annual increase in cirrhosis-related mortality. And they also observed that most of that in this younger cohort was driven by alcohol-associated liver disease. So with that in mind, this is sort of planting the seed of the burden of cirrhosis. I'm going to jump into talking about, can we reverse or can we change the trajectory? So the first section here is, the answer is yes. I'm going to use a few studies to emphasize that antiviral therapies can reduce the risk of disease progression, HCC, and mortality in patients with cirrhosis due to viral hepatitis. There are several studies that have been published since the advent of DAAs for chronic hepatitis C treatments. So I've picked a few to touch on, and then also I will have one slide that summarizes some of this in a systematic review that was published. This is one large study that I chose to highlight. This was published a few years ago using the VA national data set. It included over 62,000 vets with chronic hepatitis C, and this was from 1999 to 2015. And really they looked at, or tried to answer the question, does achieving SVR or Hep C cure change the trajectory in terms of reducing the risk of HCC? And of course the answer is yes. And you can see here in the figure, I want to highlight the different lines that represent different cohorts. the line really is showing us probability-free of HCC. So in a sense, HCC-free survival. The green line represents patients with cirrhosis who did not achieve SVR. And as expected, those had the worst outcomes, meaning the highest risk of HCC. But if you achieve SVR in cirrhotics, the green line changes to this orange line. So the orange line are patients with cirrhosis who achieves SVR or cure. And the point here is that by curing or treating Hep C, you can dramatically reduce the incidence of HCC. And the same pattern was seen in a cohort of non-cirrhotics. What about other outcomes in addition to HCC, such as decompensation and mortality? These are two studies that I wanted to highlight. The first study was a multi-centered European study of 868 Hep C patients with cirrhosis, and they demonstrated that achieving SVR was associated with improved event-free survival and HCC-free survival. And you can see that in the two figures here on the right. You can see that the drop or improvements in event-free survival from the dotted line, which represents people that did not achieve SVR, and the solid line are those cirrhotic patients that did. So an improvement in the overall event-free survival, as well as an improvement in HCC-free survival. The bottom figure comes from data just published earlier this year in the US. So they used the Optum's claims data sets, and they included about 246,000 chronic Hep C patients, and again, showed consistent findings that if you treat Hep C and cure Hep C, you reduce the risk of downstream complications. And these figures show specifically in the cohort of patients with compensated cirrhosis, which is seen here in the first figure, as well as those in decompensated cirrhosis. And so what they're showing here is the incidence of mortality, or the risk of death. And the patients in the blue line represent those that were treated, and those in the yellow line were not treated. And so again, treatment leads to a reduction in incidence of mortality in patients with both compensated and decompensated cirrhosis. And then here, I'm not going to go into a detail of every single study, but this was a very nice systematic review that was published a couple years ago in Gastro, and it highlights several important studies that looked at the benefits of Hep C therapies and how it reduces long-term risk of complications. Some of the studies in this first section here, you can see, were done in the era of interferon treatment, but there are also data that have been done and published in the era of DAA therapy. And time again, across different studies, different cohorts, different populations, you see that treatment and SVR can change the trajectory of cirrhosis and reducing long-term risk of decompensation, mortality, and other clinical liver events. What about hepatitis B? This is an older paper that was published, but a very nice systematic review that looked at the benefit of Hep B antiviral therapy in reducing risk of HCC. I highlight the red box here on the right, which specifically shows data in patients with cirrhosis. And you can see across all studies, there's a consistent pattern that treatment with antiviral therapy can reduce long-term risk of HCC, even in patients that have already developed cirrhosis. This final study in this section is a large Hong Kong-based study of about 1,500 patients that were treated with entecavir compared to 424 patients that were treatment naive. And they looked at long-term outcomes. They focused on overall liver-related events, long-term risk of HCC, liver-related mortality, as well as all-cause mortality. And again, the consistent pattern that they've emphasized is that antiviral therapy does improve and reduce the risk of all of these downstream events, and in fact can change the trajectory of hepatitis B progression. What about regression? So a little bit of a trickier question. Can we reverse or regress fibrosis and cirrhosis? And in the next subsequent slides, I will try to convince you that yes, especially in viral hepatitis, antiviral therapies can lead to regression of fibrosis and cirrhosis. This is a much, much older study. It was published in 2002, but the concept is what I'm trying to emphasize here. This is an old study, as you can see by their trial arms, looking at different doses of interferon therapy for treatment of hepatitis C. But the concept, the treatment is not so much important, but the concept is what I'm trying to emphasize. They looked at over 3,000 treatment-naive patients that were gathered from 4 different RCTs, and they looked at the impact of different doses of interferon therapy and how it affects histologic fibrosis. Paired biopsies were done with a median of about 20-month duration between the biopsies, and you can see here that they did show that treatment can change or improve fibrosis. Fibrosis stage was improved in 20% of patients, stable in 65%, and worsened in only 15%. Among specifically the patients with cirrhosis, cirrhosis, 49% achieved at least 1 stage improvements in fibrosis. And you can see here, of the 75 patients that had improvement, the different categories of their subsequent stage on repeat biopsy. This is a more recent paper, a systematic review that does include the previous study as well as several subsequent studies that were completed, and again, showing that antiviral therapy can lead to fibrosis regression. This was a meta-analysis of 6 studies, inclusive of about 443 patients with hep C cirrhosis, and they demonstrated that achieving SVR or cure was associated with regression of fibrosis. And the ranges you can see here just to highlight different studies, all of them interferon-based, but demonstrated that regression in about 24 to 83% of patients achieved some degree of regression. As suspected on their meta-analyses, that achieving SVR, of course, was the strongest predictor of realizing fibrosis regression. And this is, again, from the same paper. I'm not going to go into all the details, but just for your reference, the same paper showed and highlighted several studies, both in the interferon era, as you can see on the therapy choices here, as well as in the DAA era, that antiviral therapy, and especially achieving SVR and cure, can lead to changing this trajectory and leading to potential reversal and regression of fibrosis. And then finally, what about hepatitis B? This is one of my favorite papers in hepatitis B space. This was published several years ago, but it's a really important study that showed that antiviral therapy in hep B can also lead to regression in fibrosis. This was an open-label follow-up study of patients enrolled in 2 different RCTs that were combined. These were 48-week studies, but then the study was a follow-up open-label of 7 years of patients that were treated with TTF tenofovir. They followed up patients with a liver biopsy at week, so basically 5 years, but week 240. Of the 641 patients were randomized after all the exclusion criteria and only focusing on patients that had 2 biopsies at beginning and end, where you can actually compare. They had a total cohort of 348 patients had biopsy at both baseline and 240. And what they demonstrated that you can see first, and maybe I will focus on figure B, at baseline, year 1, and then after the open label at year 5, you can see changes in the distribution of different categories of fibrosis with the you can see here the legend, a shift towards more patients with lower stages of fibrosis, or another way of saying it, a decrease in the proportion of patients with more advanced stages of fibrosis. When they looked at subsets of patients, so you can see here in figure C, based on their baseline stage of degree of fibrosis, what percentage or proportion improved. And so you can see even in those with Ishak score of 5 or 6 at baseline, 74% no longer had cirrhosis. And again, demonstrating that antiviral therapy does lead to some degree of regression in all of these patients. And so just to summarize the main take-home points, chronic liver disease and cirrhosis remain leading cause of morbidity and mortality. And the question is, cirrhosis, can we change the trajectory? And so hopefully have been able to convince you that at least for viral hepatitis, the answer is a resounding yes, that the trajectory of cirrhosis is modifiable. Timely and effective antiviral therapies can reduce the risk of cirrhosis-related complications, HCC, and can lead to fibrosis and cirrhosis regression. We didn't have time to talk about other disease states such as NASH and alcohol-associated liver disease, but we see very similar patterns in NASH and some of the exciting therapeutics that are on the horizon. So definitely keep an eye out for those data and therapies that come out. And we know that why is this even important? Well, the importance of this is that if we can regress or reverse fibrosis, ultimately it leads to improved long-term outcomes for our patients. Great, thank you. The next talk we have is with Dr. Ray Kim, who's professor of medicine and chief of the Division of Gastroenterology and Hepatology. And he'll be talking about evaluating liver-related mortality and liver transplant outcomes.
Thanks, Robert. I don't know how many people are still online, but thank you for being here. First of all, as a chief of the division, this is our first event in person post COVID, and it's great to see everybody in person. So thank you for participating today. And you'll be glad to know that I'm the last hepatologist speaking today. And there will be a surgeon and a radiologist left before you go out for reception. So just hang in there. We are almost there. And some of the data that I'll show you have been showed before. So hopefully I'll catch on time as well. So my topic, evaluating liver-related mortality and liver transplant outcomes. So Robert just talked about trends in mortality. We'll just point out some salient points. And liver fibrosis has been talked about. Again, I'll go to the key points. I spent most of my time talking about the latest version of MEL score, MEL 3.0, and predictors of survival in patients' liver disease, liver transplant outcomes, and I'll skip over the early stage liver disease talk and then end with a take-home message. So this is the latest data from CDC about mortality statistics. You can see chronic liver disease is number 9 as of 2020. We're about 1/12 of cardiovascular, about 1/10 of cancer mortality. Granted that liver cancer death is included in the cancer bar. And if you think about COVID-19, this is 2020. As of 2022, that bar is going to be much shorter. And unfortunately, liver disease is going to move up to the 8th spot very soon. This is a more breakdown of the latest data between men and women. And first point is men die more of liver disease. Everyone knows that. Secondly, everything is going up. And as a liver disease hepatologist, this does make me feel good because we are failing to help our patients to live longer. So there's a job to be done. And if you look at the different colors, green is alcohol, red is viral hepatitis, orange is fatty liver that is labeled as fatty liver, and the purple is the other, which will contain a fair number of fatty liver patients. Everything is going up except the viral hepatitis part that went up and it went down. So nothing new here, but to point out that there is a lot of work to be done for us to reduce mortality. So when we think about liver mortality, we think about liver fibrosis. It's a key determinant of what happens over time. So cirrhosis, decompensated cirrhosis, portal hypertension, that's how our patients progress and have undesirable outcome. But way before that, patients go from no fibrosis, F0, to more advanced fibrosis F3. That is an important concept for us to keep in mind. And because we have non-invasive tests to answer the questions where they are, we are able to practice much more efficiently. A lot of times we get asked, what about this patient with abnormal liver test? And the answer to that is, where are they in terms of the scale? If they're an F0, F1, FALT of 50, if they are not going to move down this way, they're going to be okay. But if the patient has a condition or one concern for progressive liver fibrosis, that's an individual that we need to intervene. So it has really revolutionized to be able to measure the degree of liver fibrosis. So Dr. Torak talked about MR and ultrasound-based technologies to measure liver stiffness or elastography. In our office, our able assistant can do this procedure really quickly, 2 minutes, we get a result about fibrosis. For those who refer patients to us, in the referring sheet, we have a FibroScan added. So if you just check box and send it to us, we don't need to see the patient in consult. This is direct access FibroScan that you can order, and we'll get this done in a matter of a few days. You get the answer back. In this particular case, the fibrosis score is 8.9, and what does that mean? We also, Dr. Dronamraju showed this figure. Rule of 5, 5, 10, 15, 20, 25. 15 is the key landmark where you have cirrhosis. So the patient at 8.9, he's around that area. There's some degree of fibrosis, but not in a very worrisome way. So that's a patient to intervene. But my job today is to talk about this part. In the latter stages of liver disease, what happens to try to predict their outcome. This is my simplified view of what predicts liver patient outcomes. One is biochemical dysfunction, the other is portal hypertension, and the third dimension is extrahepatic organ system dysfunction. And these are the biomarkers that represent these different dimensions. So you notice in Child-Pugh score, the variables that are represented there are bilirubin, prothrombin time, albumin, ascites, and encephalopathy. That's sort of the gold standard to predict who will do well and not in chronic liver patients. So that's mostly concentrating on this aspect of the dimension. MEL score has bilirubin and INR originally and creatinine, and then sodium was added later on, and I will tell you that albumin is the new kid in the block in the MEL scale. So it covers a bit wider range of variables in terms of these dimensions. So we will talk about that. As you're familiar, MEL score was developed in the early 2000s for liver allocation purpose. It has creatinine, bilirubin, and an INR, with the creatinine being capped at 4 milligrams per deciliter. This figure shows that as MEL score goes up, there's a linear increase in the risk of death. It's pretty straight line. That's why it's useful to predict mortality in a one-on-one sort of a fashion. As we implemented MEL score in 2002, there was an immediate dip in mortality and gradual decrease, and it has gone down further, but it is contributed by the fact that hep C therapy is improved, mortality has gotten lower, and unfortunate trend of opioid epidemic provided some more organs to transplant, reducing the waitlist mortality. But overall, MEL score has that favorable impact as a whole in the population. But there was some unanticipated benefits and downsides of MEL score. And this is a study that compared pre and post-transplant waitlist mortality and transplant probability in patients who are black and who are white. So what happened in pre-MELD era, black patients were 51% higher risk of having dying on the list without having a transplant, and 25% lower chance of receiving transplant. Big disparity. MEL score eliminated that. This is because in order for someone to have transplant in the pre-MELD era, you need to have the right information, right access to healthcare, right kind of insurance to be able to receive transplant. MEL score allowed patients to show up in the ER, and if their MEL score is high enough, they will be on top of the list and get transplanted. So that was positive impact. But when they looked at female versus male, there was a reverse. In the pre-transplant, pre-MELD era, death risk was equivalent between men and women, but as we implemented the MELD score, women's death risk went up to 1.3 or 30% higher than men. In transplant, on the transplant side, even in pre-MELD era, women were disadvantaged, a 20% lower chance of receiving a transplant. MELD made it worse to 0.7. And this is a bit complex issue related to body size and so forth. We can talk about it later, but there was unintended consequences of using MELD in terms of gender disparity. So we thought about, is there a need for revising the MELD score? One reason, as multiple speakers talked about, shifting epidemiology of liver disease. There are fewer viral hepatitis patients, more alcoholic liver disease and fatty liver, older patients, more comorbidity. And that changes, for example, the significance of serum creatinine. CKD is more common as a result of diabetic nephropathy and so forth. And AKI is less important today compared to 20 years ago. Again, we wanted to do to correct the sex disparity by adding appropriate degree of extra MELD score to female patients. So the approach is to update coefficients and then consider additional variables. In this and the next few slides, I'm sharing you raw data that for each variable, we are correlating the risk of death versus the data. And the solid line here is the main effect with 95% confidence intervals. And bilirubin is very nice, like the MELD score is very linear. There's one-on-one correlation. This is INR, similar pattern, pretty linear. Creatinine is interesting that it increases the risk of death up to a point, then it plateaus out. And the bend is at around 3. So instead of 4 in the original MELD score, we lowered it to 3 milligrams per deciliter. And sodium was already in the MELD sodium score. We did not change that, reflecting hyponatremia is a bad thing for our patients. The new variable is albumin. We modeled it between 1.5 and 3.5. Hyponatremia is detrimental to our patients. So with all of that, we came up with a relatively complex equation to calculate MELD 3.0. Now you can do it with an online calculator. MedCalc and other apps will have MELD 3.0 here. So for transplant practitioners, this matters because MELD 3.0 is a better indicator of waitlist mortality. But for the rest of us, rest of the field who don't deal with transplant, what is this compared to old MELD score? We paid attention to make sure that the MELD intuition is preserved so that the two scores are very similar. So this particular figure is on patients who died on the waiting list. And the point that I usually make with this slide is there, out of 514 patients who died, 159 patients had a higher MELD 3.0 score than MELD sodium score, providing them an opportunity to go up on the waiting list so that they get transplanted instead of died. So there's a hope that these patients would have been saved. But the other point that I like to make is that the majority of patients, the score was the same. That if you have a MELD sodium of 28, for example, MELD 3.0 score is likely to be around 28. So if you're not seeing patients in the context of transplant, if you just want a MELD score, it doesn't really matter whether you use MELD 3.0 or sodium or the other scores. So this new score is going to be adopted as liver transplant metric as soon as the computer system is updated. So that's more to come in the next few weeks to months. How about post-transplant outcome? This is the data from 2020 to 2021. If you look at low MELD patients, mid MELD patients, high MELD patients, there is no difference in post-transplant outcome. It doesn't matter how you go in. Then you would ask, the difference will be in the highest MELD patients who are sick going in. They are likely to experience poor outcome. So we zeroed in on that population. It shows that it is still not very important that patients with a super high MELD score, MELD of 50, it's sort of an unbelievably high MELD score, they still do okay. 90% 1-year survival, 85% or higher 2-year survival. That's pretty decent for patients who are about to die with MELD of 50. So we're not very good predicting post-transplant survival based on MELD score. And that point is made in the next slide, that concordant statistics to see how good we are in predicting patient survival. If you look at pre-transplant survival, this is MELD sodium, and this is MELD 3.0. It looks slightly better, right? 8.7 versus 8.62. This was statistically significant improvement, and that's why we're going to MELD 3.0, in addition to the fact that it helps with the sex disparity. But if you compare post-transplant outcome, the C statistics is much lower. We are nowhere near 0.89 or so. This is an old paper that looked at original MELD score concordance of 0.6. If you added a bunch of other variables, you can maybe you can bring it up to 0.7. But it is very hard to predict what goes on after transplant. The latest data using MELD 3.0 in the pre-pandemic and the post-pandemic era, it has become even more difficult to predict how the patient is going to do after transplant based on pre-transplant variables. And that is because we have become really good in selecting patients who to transplant. So this is not everybody who's that sick. We want to make sure that the patient does has a good outcome. And also, we are good in taking care of these sick patients compared to several years ago. So it almost doesn't matter how sick they are, as long as the transplant team feel confident that they can pull them through, they get good outcome. So take-home messages. Chronic liver disease is currently the 9th leading cause of death, according to the 2020 data. A recent uptick from alcohol and others, including fatty liver. Liver fibrosis is a key determinant in liver disease outcomes. Remember the rule of 5 based on transient elastography. Dr. Dronamraju talked about this recommendation, who not to do endoscopy, and for people with a high liver stiffness greater than 25, we anticipate decompensation in portal hypertension. Predictors of survival in end-stage liver disease are 3 dimensions: biochemical dysfunction, portal hypertension, and extrahepatic physiology. MELD 3.0 is the new standard for liver allocation. It addresses sex disparity and updates the model, but the score is designed to be similar to prior MELD score for clinical management assessment. Prediction of post-transplant outcome has become difficult because of improvement in patient selection and management. And as Dr. Wong mentioned, in order for us to really make a dent in liver mortality, we need to go way upstream. Working on cirrhosis and manipulating MELD score is only going to save a few more patients. The big impact will be way early stage fatty liver patients and alcohol and viral hepatitis. So let's remember all of that. So thank you very much for your attention.
And our next talk will be by Dr. Kazu Sasaki, who's a transplant surgeon in Department of Surgery and Abdominal Transplant. Yeah, welcome.
So, hi, again, my name is Kazu Sasaki. I'm a liver transplant surgeon. I joined Stanford December 2021. So most of the people, I think, first time, and nice to meet you. And thank you for giving me an opportunity to present in this meeting. So today, I want to talk about the role of new organ preservation technique, basically liver perfusion pump in current acuity circle liver allocation system. So I thought somebody will discuss or present about the new liver allocation system, but unfortunately nobody discussed about that. So please Google it after this meeting. But UNOS started new liver allocation system since February 2020. So after the, oh, something is wrong? I think it's kind of like a slide is wrong, but it's fine, right? So after this new system implementation, who got the benefit of this new allocation system? So there's no discussion about the sicker patients got a good benefit because of this new allocation system. Those patients can get the transplants much quicker, and they get a much more higher number of offer. So there's no discussion, and many papers already proved that. But before implementation of this new allocation system, there was a huge discussion. And everybody complained about this new allocation system. This new allocation system is too favorable to the transplant program, which locates in high population area, such as California, New York, or Boston area. And people predicted that transplant case number will increase in California or New York. And so after 3 years of this implementation, our team looked into the result. And how to, maybe this one? No? It's, oh, which one? Okay. Okay. Oh, pretty difficult? Okay. So this red dot means increased case number, and the green dot means stable. And each dot is transplant center. And the blue dot means decreased case number. So in California, you can see some center increased case number and some center is stable. And in New York area or Chicago area, sorry. In Chicago area, most of the center increased case number. But in Boston area, they didn't increase case number. And you can see some of the center not very high population area like Arizona or Cleveland. Those center increase case number. So if we look into more detail how those center increase case number, we found that they increase case number by increasing utilization of the marginal brain dead donor or donor after circulation death. So in this new allocation system, utilization of a marginal organ is important. So this is a case number and the organ acceptance practice of the Stanford's program. So our case volume is keep increasing. This is a very good thing. And a much better thing is our acceptance, organ acceptance practice is getting better and better. These dot lines are national average. We are less than national average, but getting better and now a little bit better than national average. But we are still behind in accepting DCD donor or offer sequence over 50. It means marginal donor. So if we look at the Mayo, Arizona, they are way aggressive in accepting DCD donor or offer over 50, sequence 50. So our direct competitor is UCSF. They are a little bit better than us. So our program still have a room to improve accepting those marginal organs. So why we surgeons hesitate to accept those kind of marginal organs? This is nice fatty liver, probably macrosteatosis, 60%. If I use this liver without any kind of like modification, we just go straight to put this liver in, 100% I will experience post-reperfusion syndrome. After reperfusion, patient heart rate goes down, and maybe 1 minute later, anesthesiologist yell to me, chest compression, and I have to do good exercise for 10 minutes. If patients fortunately survive this post-reperfusion syndrome, still we will experience the severe coagulopathy, and patients eventually, most of the case, experience primary non-function. And sometimes we can do retransplants, but sometimes patients die. And I will be invited to the M&M, and everybody asks me, why you did that? Probably I will cry, and I will tell them, because hepatologists push me and tell me to be aggressive, right? But much worse than that, a DCD organ, addition to that, specific unique complication, it's called ischemic cholangiopathy. Addition to that reperfusion syndrome, DCD organ, even if the surgery went well, 1 month, 2 months later, patient come back with fever, high bilirubin, and we will see this bile duct dilation in CT scan or MLCP. And we have to take care of this patient for another few weeks, a few months, or a few years until they get the retransplant. So those kind of problems happen basically coming from ischemic tissue damage. It's happened from the organ procurement, and also it's getting worse and worse during cold stage. Currently, we put the liver into the ice until we put in the patient body. So smart researchers try to alleviate this issue, and they developed a new organ preservation technique. It's a famous thing. It's now getting better and better, and they developed this liver perfusion machine. Those two normothermic machine and this hyperthermic machine is already commercialized, and this new one will come soon. So liver perfusion pump, there's a two type of perfusion pump. One is hyperthermic pump. This one is kind of like a similar to the current gold standards cold storage. This machine put the liver, keep the liver to the temperature 4 to 10 degrees. It's similar to the putting it on the ice. And perfusates the liver using preservation fluids, current standard one, UW or HTK solution. In addition to that, provides more oxygen to the tissue and keep perfusates using this perfusing fluid and oxygen. But the other one is normothermic pump. This will keep the liver to the physiologic condition, 35 to 37 Celsius degree. And for that, we have to use blood. And also we have to provide oxygen and the glucose. But the difference is this one is a hyperthermic perfusion is try to keep the liver to the hibernation status, like a cold sleep. And the other one is keep it awake and give them rest. So that one of the advantage of a normothermic pump is because liver is still awake. So liver can make bile and also the clear lactates. So we can evaluate actual liver function by checking lactate clearance and how much bile production happen. Unfortunately, this type of machine cannot evaluate function very well. But good thing of this hyperperfusion pump is cost is way lower. This normothermic pump at least costs more than 40K. And if we ask a company to procure organ, 95K we have to use for each case. So we can buy Tesla Model S every case. So the question is whether this liver pump can decrease that post-reperfusion syndrome. I would like to say 100% can decrease. So this is an actual sample. I did this transplant maybe 2-3 months ago. So I got an offer, 49 years old, BMI 46. Pre-procurement biopsy shows microsteatosis 70%, macrosteatosis 50%, and a nicely yellow liver. But I put this liver on the perfusion pump and keep it 11 hours and evaluate lactate clearance. And I found that this liver is working well, so I give it to the patient, male to 26. I experienced a mild to moderate post-reperfusion syndrome because I let the fellow do the whole implantation. It took 52 minutes. It's supposed to be less than 30 minutes. I was too relaxed and a little bit surprised, but it's still fine. And after surgery, yeah, as expected, we can see a bump of the LFT and total bilirubin, but after 2 months, liver is working beautifully. So another question is whether pump can decrease complication of DCD ischemic cardiopathy. So there's a two nice journal, New England Journal and the JAMA Surgery. There is a 2 randomized control study, and both study prove that this liver perfusion pump can decrease the ischemic cardiopathy. This is already proved. And then one of the biggest strengths of this liver perfusion pump is this liver perfusion pump can increase and expand donor pool. As I mentioned, we can check the lactate clearance. And if the liver can clear lactate nicely, those liver work very well. And this is a little bit difficult to see small, but when I was in Cleveland Clinic, we did the one study. We call it as orphan liver study. We called to the OPO around Cleveland and asked them to send us a liver if nobody uses it. Then we put those liver on pump and evaluate whether it will work or not. Even those liver is in the already, once get into the garbage can and we get it. And 60% of those liver we could use to the patients, and all of the liver work well. The problem is the cost. As I said, one case is Tesla Model S, so people worry about that. So there's one smart surgeon, I don't know who he is, but he did some research already, and he checked the cost effectiveness in 10 years period. And they found that this liver perfusion pump increased donor pool 5%, and overall, this liver pump usage is cost effective. So another question is, which one is better, normal temperature or cold temperature? So first, cost-wise, cold temperature is better, and the longer storage time is normal temperature is better. And the post-reperfusion syndrome, both pump work well, and for ischemic cardiopathy, both work well. And the expanded donor pool, normal temperature is good because we can evaluate. And one of the biggest future potential of the normothermic pump is we may be able to do organ modification during pumping. So some of the researchers trying to repair those kind of fats or fibrosis, and some people is expected to kind of like make 70 years old liver and give some stem cell and make it like a 40 years old liver. So I don't know if it will happen or not, but it's good future, probably happen. And another thing is we can do immunomodulation. We can use drug and cells and genes and modify the patient's the immunoantigen, and probably we can make it a less, after transplant, less immunosuppression, or sometimes we can try tolerance induction. So some of the center already tried this one, ischemic-free transplants. Some center connect this normal thermic perfusion pump inside the donor body. So they start pumping inside the donor body. So there's no need to make it cold one time. So we can avoid ischemic injury. And even during implantation, we keep the pump working. So there's no ischemic injury. So in summary, in this new allocation system, we need to utilize more marginal organ, unless the patient whose MEL score less than 29 cannot get liver transplant. And the more and more competition happen, especially around here. So we have to, if we wanted to give liver transplant to the patients, we have to be more aggressive. And yeah, this is very important. Surgeon always afraid of ischemic reperfusion injury. And there's two type of pump, hyperthermic and normothermic. Both work well for the DCD organ and the post-reperfusion syndrome. The big difference is cost. But this normothermic pump can evaluate organ function. This is different. Even cost a lot, people wanted to do normothermic pump. And the future potential is, as I mentioned, organ modification. This is a good thing. And every time I talk about we wanted to increase case number, but we don't want to sacrifice outcome, especially at Stanford. So important thing is this pump can cost a lot, but at the same time, this pump can provide a safety. So probably we should use this pump more. At this moment, Stanford can use OCS pump, and probably soon we can introduce HOPE and a hypothermic pump as well. And maybe in the future, we will do more. Thank you.
Our last talk, this will be Dr. Peter Poullos, who's a clinical associate professor in radiology as well as GI hepatology.
Hi, everyone. I'm Pete Poullos. I'm a radiologist here at Stanford. And I'm going to be talking about the imaging of sclerosing cholangitis focused on PSC and IgG4-SC. These are my disclosures. Sadly, no relevant financial disclosures. But I should say at the beginning that imaging is just one piece of the puzzle, as you know, for the diagnosis of sclerosing cholangitis. There's a lot of overlap between these two entities, and so, you know, when I'm describing features of one, they can often apply to the other. So I'm just talking about sort of relative possibility of one disease or another having a certain finding. Just keep in mind that there's overlap. So by the end of this, you should be able to recognize the imaging features of ascending cholangitis, PSC, and IgG4-SC, and differentiate them by their imaging findings. So just briefly talk about ascending cholangitis. You can see intra- or extrahepatic bile with debris or stones, wall thickening, and then often heterogeneous liver enhancement in the arterial phase, which is not a specific finding, but can draw your attention to areas of inflammation, and I'll show an example of that. So our first case is a 76-year-old man who had a history of a cholecystectomy, but has an elevated white count and liver function tests. And you can see here in this MRCP image on the top left, you have a cute little Steinstrasse with a row of tiny T2 dark filling defects in the duct. Not much ductal dilation within the liver. Oops. On the bottom here in the contrast, oh God, this is really sensitive. The arterial phase, you can see looking at the duct in the middle of the pancreas there. All right, this isn't going to work. There's ductal wall thickening and enhancement. And then on the coronal delayed phase, T1, there is the same thing as on the T2. You can see the row of stones, and there's pretty impressive wall thickening of the duct. All right, we'll go on to PSC. So in PSC is characterized by both extrahepatic and intrahepatic involvement, but intrahepatic is especially good for PSC compared to IgG4. The length of involvement, you have these short band-like strictures, usually multiple, and the buzzwords are beating, prune tree, diverticula, focal strictures, and a shaggy appearance of the duct. The extrahepatic ducts has less wall thickening usually than that of IgG4, whereas the intrahepatic ducts have a little bit more wall thickening. Other features, and I'm not going to go through all of these, but the lumen of the thickened segment is often occluded in PSC compared to IgG4. You get weird appearances of cirrhosis in PSC with these bizarre morphologies, even like a rounded liver with atrophy of everything except for the caudate. Of course, cholangiocarcinoma. And then clinically, these patients often have IBD and are younger than patients with IgG4 disease. So here's our first case, a 20-year-old man with UC and known PSC who comes in with symptoms of acute cholangitis. You can see here on the MRCP image on the left, we have sort of a ratty appearance here of the extrahepatic bile duct with shaggy margins. And then you can see multifocal stricturing with a paucity of ducts in the periphery. And the ERCP images show similar findings with pruning and multifocal intrahepatic strictures. Not much in the way of biliary ductal dilation at this point. This was fairly early in their disease course. On the contrast-enhanced images, in the arterial phase on the left, you see these focal areas of enhancement around inflamed areas within the liver. In the middle image, you see a tiny little abscess on the top, and the bottom arrow is pointing at a little jailed off duct. And then on the delays phase, you can see that there's pretty impressive thickening of the right and left hepatic ducts. So this delayed phase thickening and enhancement is characteristic. Next patient, 23-year-old female with UC and PSC. These are some CT images. You can see on the top left, the arrows pointing to some debris within this chronically dilated duct. In the middle image, the arrows are pointing toward at the common hepatic duct, which is strictured but does not have a thick wall. And then we have a focal or dominant stricture in the left lobe on that bottom image. And this is the coronal CT scan showing similar findings. You can see the bottom arrow pointing out the inflamed right colon, and the bottom right image showing, again, the inflamed rectosigmoid from the history of ulcerative colitis. And then 10 years later, unfortunately, the patient presents with this bizarrely cirrhotic-looking liver with multifocal increased strictures and mesenteric edema and ascites. And this is the MRCP image here, which shows extrahepatic stricture as well as multifocal intrahepatic strictures. And you see that on the T2 weighted images, there are areas of, for example, in the posterior right hepatic dome, sort of high signal, typical cirrhotic appearing liver, but you have these rounded areas of darker, more normal appearing liver also. So again, the morphology is often unique in PSC-related cirrhosis. All right, next we'll switch gears to IgG4 disease. Imaging features that are more typical of IgG4 compared to PSC are extrahepatic strictures. The length of involvement tends to be longer and segmental. Some keywords include a funnel appearance of the ductal dilation or a withered tree. The extrahepatic bile duct thickness tends to be much more, and this is one of the most impressive and I think predictive findings out of all of these. And the intrahepatic ductal thickening appears usually less. And of course, you can see pseudotumors. These patients tend to be older with autoimmune pancreatitis and notably respond to steroids, unlike PSC. This is a classification of IgG4. So in type 1, you have a distal pancreatic stricture. In types 2 and 3, you have a mixture of extrahepatic and intrahepatic strictures. And then type 4 is hilar stricture. So you can imagine that there's, we see sometimes type 1 cases of IgG4 being mistaken for adenocarcinoma. Sometimes type 4s get mistaken for cholangiocarcinomas, and that's always in the differential. And then types 2 and types 3 can be hard to sort out from primary sclerosing cholangitis. So our next patient is a 60-year-old with a history of AIP and worsening LFTs. On these CT images on the left, you can see that there's ductal dilation. In the middle image, the pancreas has this characteristic sausage shape with a hypodense halo around the gland. And then on the coronal image, you can see nicely the bile duct just tapering down to nothing there in the pancreatic head, which appears enlarged. Our next case is a woman with signs and symptoms of cholestasis. Now on this MRCP, you can see that there are multifocal intrahepatic strictures. with sort of a beaded appearance that looks a lot like PSC. On the axial T2, for example, in the right hepatic lobe, you can see that there is a little bit higher T2 signal. And on the post-contrast, that posterior right lobe is also hyper-enhancing, so indicating an area that has more active inflammation, cholangitis. Now, this patient was followed and 10 years later developed these liver lesions, one in the anterior left lobe and another in the dome. And these were poorly enhancing post-contrast and were high on T2 signal. Obviously, the concern was for malignancy. You can see also, unfortunately, that like in the top left-hand image, she's cirrhotic and she has a tip shunt in place. So they got a PET CT, and these were hypermetabolic. And surprisingly, as shown on the image on the right, there were also bone lesions, lymphadenopathy, and splenomegaly. So they were concerned for lymphoma. They did a bone marrow biopsy, which was negative for lymphoma. They did a liver biopsy. Unfortunately, the first time didn't stain for IgG4 and was non-diagnostic. But when they repeated the MRI, the lesions had grown, and so they did another liver biopsy, and that time they tested it for IgG4, and it was positive. And so treated the patient with steroids. The liver tumors disappeared, but the patient unfortunately still progressed and developed even more severe cirrhosis. And you can see in this instance this relatively normal signal, very enlarged caudate, and the background liver looking not so good. And then another case, 62-year-old man with AIP. This looks remarkably similar to the first case, where you have this cutoff in the pancreatic head. On this, you see that the pancreatic head is full looking, but there's no visible mass. There is pancreatic ductal dilation on that bottom right-hand image, so understandably a concern for pancreatic cancer. A few months later, developed this appearance with long segment strictures in the hilum and in the distal CBD with very severe intrahepatic biliary ductal dilation. But the most impressive thing about this case is the thickness of the duct in the the top right picture. That bottom arrow is pointed to the thickened common hepatic duct. And this is, again, like a very good look for IgG4. The pancreas here is also involved, and you can see that hypo-intense halo. And then look at, on the bottom right, at the heterogeneous arterial enhancement consistent with cholangitis, and that the common bile duct there really stands out as thickened. And these post-con images put it in even more impressive light, just the massive thickening of the CBD. And notice that despite the fact that it's strictured, the lumen is still visible as opposed to completely lost like you might see in cholangiocarcinoma. And then it also, on the bottom right, has this funnel-shaped appearance, which people talk about also with IgG4. So in conclusion, there's a lot of overlap between the two entities. I've bolded and put some of the most helpful things in here. I think that multifocal, short, band-like strictures, especially with diverticula, and beading and pruning, highly specific for PSC, and extrahepatic, long segmental strictures with impressive wall thickening of that extrahepatic bile duct are more predictive of IgG4. So that's my talk.
First question, we'll go to Deepti. So the question, or anyone, I guess this question is, so someone with acute portal vein thrombosis in a patient with hypercoagulable state or antiphospholipid syndrome, is there a role for TIPS in addition to chronic anticoagulation? Anybody?
Feel free to speak up. I think anticoagulation is by far the the mainstay of therapy. I think if in an acute portal vein thrombosis, even more so, you should look towards anticoagulation, and maybe recanalization might be considered. I think the tips would come more in the setting of a chronic thrombosis. And in those instances, I think you can consider tips along with anticoagulation. But in an acute portal vein thrombosis, the mainstay of therapies is anticoagulation.
Questions? So maybe we'll do one more, just for sake of time, from the online poll. This one is tricky because this is for Dr. Kumari, but she's not here, so anyone can answer. Is the increase in risk of pulmonary edema seen in the confirmed trial related to unmasking of cirrhotic cardiomyopathy due to volume overload and terlipressin? So I'll add some of my comments that I remember, and then definitely people jump in to help. But I think so. If you look at the confirmed trial, I think the rates of respiratory failure was like 13-14%, and in the placebo arm it was like 4 or 5%. And I think a lot of the commentary on that was that terlipressin led to some systemic afterload increase with vasoconstriction. So you kind of increase the afterload effect, and a lot of these patients are actually getting a lot of volume and albumin, so it sort of increase the preload. And I think, if I remember the commentary, if you compare the confirm to a lot of the other trials that Dr. Kumari were mentioning, such as the reverse trial, and there was one other trial, the levels or the amount of albumin was much higher given in the confirmed trial. So it was sort of a combination of effect: increased preload, increased afterload resistance. And then also when they did sub-analyses, I remember there were certain subsets of the population that really drove the increase in respiratory failure. I think those with higher ACLF, higher MELD score, and probably higher degree of multi-organ failure. But definitely, please add if other people have more insight.
It's hard to, the paper doesn't report specific cardiac workup for those patients. So the answer to that question is difficult to provide with a certainty. But my gut feeling is that it's more volume related rather than unmasking cardiomyopathy in that situation.
Great. Any other questions? Well, with that, we'll end the session, and thanks to all the speakers for giving wonderful presentations.